Today's speaker is Jane Iatrou, and Jane is a registered nurse with an interest in acute medicine, and Jane's got over 20 years experience as a senior nurse in intensive care, and also spent time working in clinical education. These days, she works as a transfusion nurse practitioner at Mersey and West Lancashire teaching hospitals. And today, Jane is going to join us to talk about blood transfusion and the management of burns. And just before I hand over to Jane to start today's presentation, just a quick note that this presentation does contain some photographs of some wounds and some burns, and we'll go into some detail about some quite traumatic case studies. So just a heads up for anybody that might find that content distressing. But without further ado, I'm going to pass over now to Jane to begin today's session. Thank you.
Hi. So I'm going to tell you how we look after somebody with severe burns. And these are burns that are over 40 to 60% of the body, and which we see on intensive care, and how we look after them on intensive care. The aim of the talk is so that you in the lab can understand and prioritise your blood products, and also have an understanding of when we might need them and why we need them and what we use them for. So, burns are a major burden for the healthcare service, and they account for more than 300,000 global deaths a year. The fatality of a burn is directly associated to the percentage of burn on the body. And this was created by the Bogue score, which was created about 20 to 30 years ago. And it basically said that your percentage of burns give you an idea of how much mortality someone was going to have, how likely they were to die. So somebody with an 80% burns only had an 80% chance that they were going to die, and it's a really hard thing to manage at the other end of the scale. And in the clinical area, it's really hard. But we've had improvements in our practice, improvements in fluid management, nutrition support, infection control policies, surgical techniques have all improved, and our statistics are much better nowadays. And the last statistic was a 25-year-old young boy with a 50% total burn had in 20 years ago, according to the Bogue score, they had a 50% chance of dying. And now we've reduced this to 10. So we know that no matter how much somebody is covered with burns and how deep they are, we will always give the best care to them to get them better. Now, there's lots of different types of burns. The ones that we mostly see are thermal injuries, and these include flames from petrol being poured on somebody, or ignition of clothes by candles, or an open fire in the house, or cigarettes being dropped on the clothes and causing burns. House fires are a problem, and our household appliances are the main cause of it. Burning rubbish in the garden is a big one, and then people go and get chemicals and throw them on the fire to ignite it, and unfortunately they have a flash burn. It goes back and it burns them. Scalds are quite bad, especially in children, and these can be scalds from baths, kettles, or hot drinks. Electricity burns are few and far between, I'm glad to say, but the problem with an electricity burn is it always goes deeper, and the electricity can affect your heart because your heart has electrical conductivity, and this can lead to big heart arrhythmias, which we'll have to deal with at the other side. We do have a few cases of plumbers coming in who've had electrical burns. Chemical burns due to acids being thrown into people's faces, violent attacks, we still have those, and radiation from sun tanning booths, although those are getting better. We always worry about bonfire night, because bonfire night is going to mean an increase in people coming in with burns. Now, how to initially manage somebody when they're outside and you see somebody with a burn is the 3 C's. So we cool the air. If you're anywhere where you can cool the area, it's advisable to cool a burn. And that means putting it, rinsing it under cold water for about 20 minutes. Ideally, just do the burn, because if you did the whole of the body, it's just going to lead to hypothermia, so a low temperature, and you can send the patients into shock. We had a lady who had the majority of her body covered in burns, and she ran up to the bathroom and showered, which we thought was so brave. And it meant that the inflammation that was caused by the burn was reduced, and so it improved things slightly for her. So cooling is the first of the 3 C's, and then call for help, and finally cover with cling film to keep it clean. Try to use a non-stick dressing, because you don't want anything making the burn worse. But if you haven't got any cling film, then just something that's clean, maybe a clean tea towel for over the top of it before they come in. Now, running onto a scene to assess a patient, the important thing is to see if they've got any inhalation injuries. So you see in the first picture here, there's got this swelling to the face is caused by edema. So it's caused by fluid. When someone's got burns, they've got an intensity of heat to that area, and that makes the brain sends lots of fluid to that area, plus lots of other chemical mediators to that area to try and cool it down, but it causes excessive swelling, as you can see. Notice how the mouth has nearly closed over. So the important thing when we're assessing a patient is to look for any forms of soot in the mouth, in the nose hair that have been singed, any nasal cavities that we think have been burnt, because what we don't want is to lose somebody's airway. So if we think their breathing tube is getting completely swollen, we need to try and put that tube into his mouth there. We'll go onto a ventilator, and that'll mean that no matter how swollen the inner sides get, it's not going to compress your airway, and you're not going to lose your airway. So that is the most important thing that we do for these patients. Now, examining a burn and seeing how bad it is, the more severe it is, the more fluids they're going to need. Because if you can imagine to here, you're losing all this fluid. So you're losing the fluid from your central circulation, and we need to replace that so they don't dehydrate. Because if someone dehydrates, they're going to go into kidney failure. We want to avoid that. So to do this, we need to work out how much percentage of the body does the burn covered by, and we use the rule of nines. So the rule of nines was brought in by the Advanced Trauma Life Support course, and it is a really clever rule that determines that each part of the body is either a multiplication or a division of 9. So your torso here and your abdomen at the front is 18%. The back is 18%. The 2 arms at the front are 4.5, and then the backs are 4.5. And the 9 and the legs at the front are 9%, and the legs at the back are 9%. Front of the head is 4.5, and the back of the head is 4.5. And this is for an adult body. So when somebody is admitted, we will have a body map, and we will draw the body map exactly the same as here, and mark off 9% for the legs, 4.5 for the arms, and then we'll top them all up so we get a percentage of burn on the body. And the higher the percentage of burn, the more sick they are. Burns of over 30% have a potential to get very, very sick. Any small burns around the body, so say they just had a very small burn on the top of the leg, we can use the patient's hand. That is 1%. So the palm of the hand and the fingers including over the area that's covered, that would be 1%. And we could use that as an alternative if all the limb wasn't covered, and do it that way, and then tot it up the same way. But it has to be the patient's hand, because your hand is not in proportion to the patient, so it can't be your own. So the severity of the burn and the fluid management is based on the rule of 9, but it's also the deeper the burn is, the more severe it's going to be, and the more fluids we're going to need to give them. So depth of the burns now. We're going to start with superficial burns. And I want you to notice on this picture, this is our layers of our skin. So the first layer is the white layer, which goes to the pink, and that's called the epidermis. And then the second layer goes from the top of the epidermis to the subcutaneous tissue, and that's called the dermis. And underneath that is the subcutaneous tissue. Now, this is a young boy that's fallen asleep on the beach for a couple of hours, probably. And he's showing a large erythema white rash. And all that means is the top layer of skin, the epidermis, has been burnt away. So the white has been burnt through that, and it's gone through into the pink layer, which is why you see pink layer. Now, if I put my finger on that, it would blanch. So it would go from white to pink. And that's really important because it shows that your capillary blood vessels, which you have a look in the dermis section here, the blue and the red, they're still there. So that means that it's going to get better and it self-heals. So it's always good to know that it's a superficial burn. It will improve. It be painful, but it will improve in about two weeks for this person, and it doesn't scar. In fact, in an older person, they might have better skin once it's peeled off and then fresh skin comes through. This generally doesn't need IV fluids, but obviously there are some cases where people get sunstroke and which can dehydrate. So not in all cases, but it generally doesn't need IV fluids. So I kind of like talking about that because it's got a really, really very good outcome. The next is partial thickness burns, and this is divided into partial thickness on the side here and full partial thickness. So partial thickness, and I want you to have a look in the picture at the bottom of the different layers of the skin again. With both partial thickness and deep thickness burns, you've gone through the epidermis and you're into the dermis. Now just notice that the dermis consists of two layers. You've got a pink layer at the top and a lighter pink whitey layer here. So if you notice in the partial thickness picture, this is a very pink, very red. So we're just gone into the upper half of just burnt into the upper half of the dermis here. It's moist, you can see it's moist there, and it's painful, very, very hypersensitive. So if you were looking after somebody with mostly partial thickness burns, even the air will hurt that burn. It's so sensitive. So we would have a sterile dressing over the top, and as we assessed it, we just lift it up gently so that the air is not circulating around it because it's so sensitive, and they'd be on a lot of painkillers to help them with this. Now, it's going to blister, and the purpose of a blister is to keep that fluid on top of the burn, to cool the burn down, to heal the burn. And we don't break a blister because that's what it's for, and to heal it. Now on the picture, they've had a blister here, but it's dehissed, it's de-roofed, and it's taken the top off. It's moist and it seeps all the way through. If I wouldn't touch this with my bare hands because this is now open to infection, we're going to have to dress it. But if I was with a gloved finger with good hand hygiene, if I was to touch it, it would blanch, which means that the capillary blood vessels are still getting to it. So this should heal itself as well. Then we go on to deep partial thickness. So by here, we're going through to the bottom layer of the dermis. You might think that because it looks white, it's improving because it's getting similar to its own colour skin. But unfortunately, the whiteness on here shows that it's going more dead. The tissues are losing the circulation. And if I was to press it, it would not go from white to pink. It does not blanch, so it's becoming dead. You might just have little impigments here of red, but this is will not heal and will need to go for surgery in the future for debridement and grafting of it. It had no capillary refill. And then finally, we go on to our next slide, which is our full thickness burn. And this, unfortunately, is what we see a lot on intensive care. We've gone through the epidermis, into the dermis, and we've gone right down into the subcutaneous layer here. The subcutaneous layer is like a yellowy colour, maybe white. And what you see here is the leathery, waxy, leathery texture to it. And I want you to imagine it like leather because it is dead skin that's happened. If you notice the brown bits up here, that's dead skin, which will just naturally come off itself. It will flake off. And you notice the red up here. Unfortunately, that does not blanch, so doesn't show you capillaries are underneath. That's necrotic skin as well. So the white here is white, leathery, chalky. This does not weep. And the problem with this is because it is like leather, it's lost its elasticity to the tissues completely. So in a burn that's all the way around, circumferal, it's a massive cause of concern, because that, if you can imagine that when somebody burns themselves, you have a mass influx of water to the area to try and cool it down. If you've got a tight leathery tourniquet on that, which is what the burn is, it's not going to be elastic and move at all, and it's just getting tighter and tighter and tighter. And when it gets so tight, it can stop the blood supply to the area, so the pulses can go, and therefore they can lose that limb. And this is called compartmental syndrome. So when compartment syndrome, and when people are admitted in the first 6 hours of being admitted into hospital, this is what we're looking for. Have they got compartment syndrome? Have they got it across the chest? Because if they've got leathery 3rd degree burns around their chest where it's constricting their breathing, and they're not able to breathe at all from it, this is going to mean that they lose their oxygen levels and they're going to deteriorate very, very rapidly. If it's to the abdomen, it's a tourniquet around the abdomen, and you can cause pressure on the aorta, which is the main blood supply, with supplying all the nutrients to all the organs. So it's very, very, very dangerous. And if somebody has got compartment syndrome, what we need to do is to do scrotomies. So this lady has her arm, which is 3rd degree burns throughout it, and she was having compartmental syndrome where she was going to lose her pulses in her wrist. So we had to make sort of an incision all the way down, and we have to do it so we're not going to hit any main arteries, or we're not going to hit any main muscles for her. So she's got the scrotomy down the bottom, and it's through diathermy, and diathermy is like a very, very hot wand that seizes through the tissues. And the next thing, all this water that's built up and the built up of pressure seeps out of it as you do it. When someone has a scrotomies, they're going to lose a lot of fluids and they're going to lose blood at the same time. So the main thing of treating a burn is fluid management. And we do the fluid management using the Parkland's formula. And the Parkland's formula was created as an estimation of replacing all, if you can imagine all that fluid to the area, and it comes out of the wound because you've got no skin to hold it in, and it seeps up over the floor and evaporates through the room. We want to replace all that fluid, so that we're replacing the fluid in the blood vessels, so that all our organs mostly the kidneys don't dehydrate, but also we want to give the fluid back to the tissues on the side, so that any burns that are second degree burns that have a chance of healing can heal with the fluid management that we're giving them. And we do this through the Parkland's formula. So there's different types of Parkland's formula, and the first one that was created, it says here, this is ours. This is 1.5 mils per kilogram per percentage of total body surface area. But the original Parkland's formula we used was 3 to 4 mils per kilogram, times by your kilogram of body weight, times by the percentage of burn on your body. And we use this for second and third degree burns. And we use it when they get over 20 to 30% of the body that's been burnt. So, for example, if we have a gentleman that's 100 kilograms and he's got 80% of his body is covered in burns, it's 1.5 mils times 80 times 100, which gives 12 litres of fluid. And that's a lot. So in you or I that no burns at all, we'd be aiming for 2 to 3 litres fluid management in the 24 hours. So as you can see, we're expecting burns to lose lots of fluid and need lots of fluid replenishing. So that 12 litres we're going to give over 24 hours. Now we know that somebody will lose the majority of fluids in the first 8 hours. So we're going to give half the amount, 6 litres, over the first 8 hours, which makes 750 mils an hour. And the remaining half, which is 6 litres, we're going to give that over the next 16 hours at 375 mils an hour. But this isn't set in stone. We're going to start the Parkland's formula, and then we're going to use the urine output to make sure that the kidneys don't dehydrate or don't have fluid overload, which is also very bad. And we're going to aim for an adult of 0.5 ml per kilogram of body weight and go up and down on the rate as we need to. If we get excess urine output, then we will reduce the mils per hour, and if we get too little, then we'll increase it. So now it comes on to which fluids do we use? And this is a massive debate between crystalloids and colloids. In World War I, we actually used blood, but it was found that blood didn't have the massive volume of fluid that we needed. And it still led to dehydration, which led to kidney failure. During Second World War II, we realised that it was fluids that we needed. And once we'd worked that out, we created the Parkland's formula, and we started to increase prognosis rates significantly. So these are the different types of fluids that we use now. They're crystalloids and colloids. So the picture here on the left is Hartmann's. The middle one is sodium chloride with 0.9% saline, which is just salts. And then finally, albumin 20. You get 4.5% and you get 20%. This talk is just on the 20% that we use. So Hartmann's, all it is a bit of water with some ions in it. And if you can, I don't know whether you can see whether it's up to there, but for sodium content, each litre contains 130 millimoles. And then potassium's got 5 millimoles in it, calcium chloride, and it's got a bit of lactate in it in the form of bicarb. Sodium chloride 0.9%, that's a litre, and each litre has more salt in it than the Hartmann's. And what we found was when you use sodium chloride 0.9 and give lots of it, it increased the sodium levels in someone's blood, and that can dehydrate somebody, and it can affect the brain. So we try not to use lots of boluses of saline for that reason. And because the burns need so many fluids, we like the Hartmann's. The Hartmann's has a balanced amount of its ions, and that amount has been cleverly calculated so it's the same as your normal ions that are in your body. So the sodium levels, the potassium levels, the calcium levels in it are the same that's in the plasma, in our plasma. So it's a balanced amount, and that's why we use it in our burns. Now, I want you to imagine that I'm administering this Hartmann's now, and I'm running it at 500 mils an hour, however many mils that the Parkland's formula has suggested for my percentage burn and my depth of my burn to get it better. And I'm administering that IV, and it's going into up to the heart and through to the aorta, and from there on it's going through to the capillaries in the tissues here. And then the middle picture here shows that capillary in the tissues. And in the capillaries, you've got the red cells and you've got the plasma that surrounds it as well. You've got small gaps in between the capillaries. Now, this is your tissues. So these are the burnt tissues here in our burns. And the aim of management is to repair this burnt tissues. And to keep them perfused. And if they're not going to burn, if they're a 2nd degree burn or a 3rd degree burn, it would have to, after doing grafts of them and to promote the healing to the grafts. So we're going to administer Hartmann's here, and just imagine that all this is burned. Now, in between the capillaries and the tissues is interstitial fluid, and that contains water, sugar, carbon dioxide, salt, fatty acids, hormones, and oxygen. And that is, all those components are really important to try and promote the tissues and keep reperfusing the tissues. So now we've got Hartmann's that's going through into the blood vessels. The pressure in the interstitial fluid is called hydrostatic pressure. And if somebody's got a big burn, all these tissues are going to be destroyed, and the hydrostatic fluid just flows out of the burn into the atmosphere. So you lose the interstitial fluid and the pressure, which means that as we minister the Hartmann's into the capillaries, because the molecules are very small, they naturally go through the capillary walls and into the interstitial fluid. And this is trying to heal the tissues all the time and reperfuse all the tissues all the time. If we give too much, the Hartmann's will go back into the circulation through the lymph nodes and back round the circulation through the lymph nodes here. So Hartmann's is really good at this. And if you can imagine, this is your capillary there, what you see. If I give Hartmann's, that's my volume of Hartmann's now, it is so good at moving the fluid from the capillary into the interstitial space that 75% of the volume that I administer goes into the interstitial space here to promote the tissues and get them better. The downside of this is that after a while, because that Hartmann's goes over interstitial fluid so well, 75% of it, if you can imagine me putting it in and then 75% of it's lost into the interstitial space, that capillary now has only a quarter of the volume, and that's dehydration. When that goes through to the kidneys cannot function with that little blood volume. In practice, we will increase the Hartmann's and try our hardest to increase the volume in the capillaries again through using the Hartmann's. But sometimes if the burn's that extensive, it's resistant to the Hartmann's, and all that's happening is the Hartmann's starts to build up and build up and build up in the interstitial fluid, and it can increase the chances of compartmental syndrome again. So when this happens in clinical practice, if the patient's dehydrated, they'll have a low blood pressure, because you can see there's no blood volume in that capillary and the pressure's really low, so you're going to have a low blood pressure. And this is called burn shock. which is very bad for the kidneys, but also it means that there's not a lot of nutrition getting through to the tissues and the rest of the body to keep them going. So in which case we have a drug called noradrenaline. Noradrenaline is not a volume expander, unfortunately. It's a vasoconstrictor. So noradrenaline will send your blood vessels from being this big, where the pressure is very low in it, you've got a lot of air through it, and it tightens the blood pressure so that your increase in the blood pressure in your capillaries comes up to give you to allow more blood pressure through to the kidneys so the kidneys can start to function. Now, we try to use noradrenaline as little as possible because it has large side effects. We know that the more noradrenaline we put on somebody, it's going to mean that that volume hasn't increased. So there's still very little nutrients get into the tissues, nutrients get into the heart, lack of oxygen get into the heart and lack of oxygen get into the tissues, and it means that the tissue is going to die more. So to stop us from using the noradrenaline, we've got albumin as a rescue therapy. So if we go back to our old sheet, so this is albumin now. It's 20% albumin, and it's what you supply in your laboratories and your transfusion. Now, the great thing about albumin, 20% albumin, is it's a big volume expander. Let's go on to the next one. So here we've got our blood vessel with very little volume in it because we've given Hartmann's, and Hartmann's has just gone into these interstitial fluids instead, and we've lost the pressure and we've lost the volume. And then we administer albumin. However much albumin we insert into the body, it will increase its volume mass by 4%. If I give someone 50 mils, about 20% albumin, it increases it to 200 mils. So watch 50 mils, and all of a sudden it is a volume expander. You've got 200 mils as soon as it reaches the circulation, and that means that the blood pressures come up, the kidneys are now supported, but even better, it's fluid. So you've got fluid that to support your tissues and to support other organs. And that's the beauty of albumin. But it goes further than that. The molecules of albumin are really large. So if you can imagine in the capillaries, all this albumin floating around that we've just administered, the molecules are so large that it's not like Hartmann's, where 75% goes through into your interstitial fluids. The majority of it doesn't go through into your interstitial fluids, so it stays in your blood circulation for longer. But finally, the third superpower that it's got is the osmotic pressure, and we call this the colloid pressure. Because the molecules are so big floating around into the capillaries, the water from the interstitial fluid is actually drawn back into the capillaries because this osmotic pressure that the albumin brings is so great, it draws it in with it. So it's even better because it keeps the volume in it for longer. The problem with albumin was that when it was first brought out, we did studies in sheep to show that when sheep are burned, what happened when we administered albumin. And what happened was the burn burned the tissues. So it burned these tissues at the bottom were all singed and burned. And if you imagine the capillary wall here, the heat and the intensity from the burn meant that there was large holes in the capillary walls. So even though the albumin is a larger molecule, it doesn't normally go through it, because the heat was so extensive, the albumin could go through interstitial fluids. Now, albumin is not like Hartmann's with small molecules, it's big. So any extra that we're given and it's not used up it's too big to go through the lymph nodes, and it gets stuck in the interstitial fluids. And for this reason, we stopped and we brought it off the market. And then years later, we did the studies again. And we realized that it wasn't always the case. And if it was the case, we did studies after 8 hours of the burn, and we worked out that on sheep, it was animal studies, not human studies. On sheep, the burn repaired itself after 8 hours. So the chances of albumin going through into the interstitial space were significantly reduced after 8 hours, which is why on our protocol, we will have Hartmann's to go in through interstitial fluid and repair the tissues. And we start with that with the Parkins formula from the minute they are admitted, or sorry, not the minute they're admitted, but the minute that the injury starts, we start the Hartmann's. And then when we start to think after 8 hours, then we'd start the albumin, and not before if we can avoid it. Now, the research behind this is not extensive, and it's not great. It's mostly retrospective research. There's hardly any prospective research out there. So there are different opinions about when to start administering albumin and when not. Some consultants use it on the 8 hours to stop noradrenaline going up, and to increase the chances of survival that way. Other consultants use it as a rescue treatment when the patient's becoming dehydrated, to stop the kidneys from going into shock. And then the final fluid that I just wanted to talk about just very, very briefly is fresh frozen plasma, because fresh frozen plasma isn't seen in transfusion as an indication to use in blood. But actually in the Second World War, it was blood was very, very scarce. So they brought out fresh frozen plasma, and it was used as part of the fluid regime. They diluted it with water to try and get the volume. And what they worked out was that the patient's tissues healed much quicker. And this was because the fresh frozen plasma contains all your clotting factors, and they heal the wound. So actually patients did really well off fresh frozen plasma, which was diluted with water. The problem was that after the Second World War, it was taken off the market because a lot of people that had received this fresh frozen plasma contracted hepatitis from it. So it was quickly withdrawn off the market. Now, I know you know this better than me, but our practices in the laboratory are much better than they were years ago. And now the chances of hepatitis are really, really, it's much safer. And so there is studies that there is people that are looking into the International Society of Burns Injuries and American Burns Association survey are looking into doing studies of fresh frozen plasma and to see where its place is in burns. So we just need to watch this space. But I have great, I just want to know what that's going to be like for. It's quite exciting. And then this takes me on to the last part, because I've only got about 10 minutes more of my talk, and it's about about your blood loss in burns. Burns isn't like a major trauma where you cut off a limb and you've got a massive major hemorrhage straight away, where you need to activate the major hemorrhage and lose all your blood volume in a short amount of time. It's a more chronic bleed from small burns when you've taken off the first layer of skin. And then you have a large bleed during the theatres. And each surgery is expected to lose 2/3 to a half of your circulating blood volume. But the bleed is very multifactorial. So this shows all the causes of what makes somebody bleed, what makes their coagulation cascade deteriorate, and all the different things in a burn that affect it. Now, as for the coagulation cascade, in the first few hours, fibrinogen and thrombin and the clotting factors start to multiply as the brain is trying to heal the wound. But unfortunately, due to, it's called SIRS, and it's the 1, 2, 3, there's the fourth box along. So SIRS is a massive inflammatory response syndrome, which has been talking about when you've got a burn, your brain sends lots of water to the area to cool it down. So in the first few hours, the clotting cascade goes up and you get more fibrinogen, thrombin, and clotting factors. But then this massive inflammatory response of water that goes to the area dilutes all the clotting factors and the hemoglobin, meaning that you lose them and you do bleed more within a few hours of the burn. And then to add insult onto this, we give somebody lots of fluid boluses and lots of fluid management with the Hartmann's protocol, and this dilutes the clotting factors and the hemoglobin even further, so that worsens the bleeds and makes them bleed more, and they lose the clotting factors at the same time. Now, if you imagine the damage to the tissues here as they've lost all their skin, but I just want to emphasize the point that it's not just the skin and all the 3 tissue layers that you're going down. The heat damages your blood vessels and everything within your blood vessels. This is a slide now of and it's a slide of a 57-year-old man that was brought into A&E following a house fire. He was severely dehydrated and he ended up arresting. We did a full set of bloods before he arrested, and we found his hemoglobin to be normal on the analyzer, but his platelet counts were 979. They were excessively high, and it didn't sit with the story of what had come in with his burn. So we manually counted them instead. And when they were manually counted, it wasn't his platelets that we'd seen, but his red cells that had been fragmented by the heat of the burn and caused hemolysis. And all we saw was microspherocytes instead, and the platelets were normal in him, but the red cells were significantly low, and that's what had made him arrest. So it just, the case shows how difficult it is to analyse somebody's coagulopathy and their hemoglobin levels, because the burn affects the inner blood vessels as well as the tissues themselves. And then my final slide is on a case study of an 18-year-old girl who had 98% full thickness burns. And you can see that I have drawn in there that her full thickness burns. So they've gone through the epidermis, the dermis, and right into the subcutaneous tissue all the way along. And remember that 2nd-degree burns and full thickness degree burns will need briding and degrafting. So briding just means that the burn is removed, the dead skin is removed in surgery, and they harvest and they put on skin grafts on top, which look like a net of skin grafts which go over the top, and then they harvest and they embed themselves into the skin to improve it. Now, this lady had the majority of her skin burnt, and can you see the only things that were spared were this bit here underneath her chin, the size of her neck, the size of her sides of her abdomen here, and in her stomach, and the sides of her groin here were the only things that were spared. So when she went to theatre, the first thing that they were going to do is take a culture of her own skin and send it off to the lab for harvesting, so that, because the best grafts are your own grafts. In the meantime, she would need grafts from somebody else. Now, when she came in, she did have circumferal burns, which which were all the way around, and she needed hysterectomies to reduce the pressure in them. The second day, she went to surgery. Now, we don't debride and put grafts on the whole of the body, because if we did, they would lose a massive amount of fluid and just go straight into shock. So we will do little bits at a time, and this lady needed 10 operations in total. And we'd start at the front, and we always do the back last, because you don't, after someone's got a skin graft on, it's not advisable to lie them on that area because the graft won't take. So we did the front abdomen first and the arms first, and do it little by little. Now, prior to surgery, we know that they're going to lose an extensive amount of blood and fluids. So before she goes to surgery, we will aim for higher hemoglobin thresholds than you would in a restrictive policy, and it depends on which consultant and what surgery we're going to undertake for that day and what expected blood loss it's going to be. So for her first surgery, we were aiming for, because this first surgery is always the worst, aiming for a hemoglobin of more than 10, and she needed 2 units of red cells to top her up before she went to surgery. In the surgery, she used, and we had the same amount prepared, and she did use all her blood, 10 units of red cells and 4 FFP and 1 platelets, and she needed a significant amount of Hartmann's as well. After the surgery, her hemoglobin for the next 24 hours would drop just to less than 8, and she needed 2 units of blood just to top it up just to above the 8. Now, she needed surgery. We planned for surgery for this lady every Thursday, so we had a set plan, and in between that surgery we would have to keep the skin clean by doing regular dressing changes on it, and she was and baths as well, because we'd highly researched baths as well with her. So every Thursday she was going to surgery. And it was pretty much the same amount of blood that was used, and just solely tailored off as her burns started to improve with the surgery that we'd taken. So, for example, the second surgery only needed 8 units of red cells, 4 FFP and 1 platelets. And then the third surgery just needed 6 red cells, 4 FFP and no platelets. And then overall, they were approximately 6 to 8 units of red cells were used, 2 to 4 units of FFP were used, and 1 unit of platelets were used in the first 2 surgeries. And that was the general pattern that was occurring to her. In between surgeries, we could stick to restrictive hemoglobin thresholds and just top up with a couple of units of blood. And then obviously in surgery, she'd have tranexamic acid as well to reduce her bleeding. In total, she needed 65 units of red cells and 2 FFP and 2 units of platelets. So in between surgery was more of a stable low grade bleed, which was completely manageable. It was more in surgery that it was impossible to stick to any form of restrictive hemoglobin levels. But her bleeding was multifactorial, which is what the aim of this case was trying to get through to you. And the first thing that really affected her bleeding levels was infection. Your skin is your main protection against getting any forms of infection, and once it's gone, even flora that's normally on the surface of your skin that's not doing any damage at all can get into underneath the skin, and that can cause sepsis. And by day 4, she was becoming septic, and in a sputum sample we picked up strep A. which was the cause of it. And her temperatures were swinging from 35 to 39 degrees. And this is a problem for bleeding because it increases your bleeding and decreases your coagulopathy. As you get very, very low temperature levels, your coagulopathy goes down. And if you get, and also your burns don't heal. So we aim to keep the room warm, shut the doors, and increase the temperature of the room to increase the temperature of the patient, so that we're promoting the wounds to heal of the temperature of the patient. And the infection was leading to very high temperatures of 39 or 40, which led to sepsis, low blood pressure, which needed increasing fluid management to manage them as well. And that fluid management was diluting the cascade and diluting the causing factors, diluting the hemoglobin, and making her bleed worse. And the chronic bleeds in between the surgery went from 2 units being transfused to aim to get a hemoglobin of 8 to 4 now being needed to get that hemoglobin of 8. On the 3rd week, she developed gram-negative cocci in a line tip, and she'd been on 3 to 4 different antibiotics now. By week 5, she developed multi-resistant, because of all the antibiotics, Pseudomonas. Now, Pseudomonas is a severe bug in burns, and the reason why it's severe is it quickly spreads. And that's exactly what happened. It spread from one area of the skin to all the other areas of her skin. So it's hard to manage. And she needed a very potent antibiotic for it. And she needed extra fluid, which dilutes the clotting factors and leads to more chronic anemias. On week 6, we were starting to wake her because we were managing the Pseudomonas well, and we were starting to wake her, and she was responding, but she was significantly short of breath, and it was quite acute. And we realised that she had a small PA, she had a small pulmonary embolism. And then on week 7, and we had to liaise with the haematologist, and she was already on Clexane since admission. We had to go up and give a treatment dose Clexane to overcome it and liaise with the haematologist. And then on week 7, she struggled with very, very low electrolytes. So she struggled with low magnesium, phosphate, calcium, and very, very high lactate. And it was higher than we thought it should have been for the sepsis that was created by the Pseudomonas. She was having very low albumin levels of less than 20, and she was very hypertensive with this very low albumin levels. And even worse, it affected her bone marrow. So she was now becoming pancytopenic. She had low red cells, low white cells, and low platelets. So she went for a CT scan, and the CT scan showed that she had fatty liver. Now, during a burn, if it's a large burn, it's going to need a significant amount of energy through your nutrition to get that burn better, and that leads to a hypermetabolic response. And the body uses up all its energy stores to compensate for that hypermetabolic response, and it uses all its fat energy resources, and this has increased the lipids in her body, and it had led to fatty liver disease. And we had to ring the hematologist and get the speciality about how to get this lady better. And she'd already had nutritional support with expert nutritionists, but this had to be adjusted because it not only had to be low in lipids, so we didn't make it any worse, but it also had to be tailored to the right amount of calories. So we gave her enough calories for the wounds to heal. And this is specific as well to the patient. So every time you change her wounds, you increase the calorie intake. Every time she goes for surgery, mobilizing, it all increased the nutritional needs. So each day would have to be reassessed and the right amount of nutrition given to her. And we worked out that she was vitamin K depleted as well, and she needed that. I'm glad to say that this lady did get better, but it was a slow progress. But the case study is very, very good, so that when you're analysing patients that are bleeding, it's not just a surgery that we think about how much blood they're going to use, but there is multiple factors that cause the bleed. And this is hypoperfusion of the tissues due to the burn, hypothermic, being very, very cold, making sure we shut the doors, keep the room temperature high, and my word, it's hot in those rooms. And the endothelial damage that's caused it, giving them lots of fluid to resolve all that, just consumes those fostering factors. That SIRS response is massive with the fluid that's brought into that, and we need to replace that fluid. And all these factors affect the clotting and coagulation and the bleed of a patient, and they must all be considered, not just the immediate surgeries. I hope you've understood at least a little bit of that. And I hope that now when you administer HAS, you understand the decisions that we're making at the end of the bed and why we're trying to do that to help each patient get better.
Jane, thank you so much. We're having a lot of thank yous there in the chat. I think I can concur actually that was such a hugely informative presentation and really fascinating. I want to say thanks so much, Jane, for your presentation today, and huge thanks to all of our BMSEDG members who have come along to today's event. Part 2 to this presentation will follow in a few months' time, where we'll look at blood component therapy more specifically. So just a few of the usual bits. I'm just going to change our slide over. We've got one with a QR code with a link to the evaluation to today's session. This link is also available in the joining instructions email, and I'll be popping it in the chat very shortly. Completing these evaluations is really helpful for the BMSEDG team and will result in the send out of certificates in approximately 7 days to those who have completed it. To those that have registered to the BMSEDG and subsequently have come along to today's session, there's no need to register again. You'll automatically receive invites to our monthly events. We meet on the last Wednesday of every month at 2 p.m. UK time. To those looking to register, make sure you're extra careful when you enter your email addresses. Due to GDPR, we're unable to amend any typos in the email addresses. We look forward to those able to join us for next month's session. We'll be meeting with Victoria Tuckley of the SHOT team for an expert analysis into the 2022 SHOT report, and that will be on Wednesday, the 27th of September at 2 p.m. UK time. Great. So, Jane, we've had a couple of people asking, are we able to share the slides at all to those who evaluate our event today?
Yes, of course, that's fine.
Amazing. Fab. Thanks again, all.
Thank you very much. Thank you.